Thanks, Shreyas, and thanks also for the opportunity to participate in your instruction course. Looks like it's going to be a really exciting one, and also thanks for accommodating the request to actually change the topic slightly. One of the reasons why I had thought that it would be important to speak about experience on keratoconus from the past is because of the fact that there are several learnings that we can apply to predict what will happen in the future. And the data that I'm about to share with you is going to be looking at how things have changed in the last 30 years and why the future might be slightly different from what we are used to in the field of keratoconus, and what skills do we need to enhance from the point of view of dealing with these patients and where to look for these patients in the future. So it seems that at least what we think is the prevalence of keratoconus seems to be on the rise. Keratoconus is potentially commoner in certain geographies and ethnic groups, and seems to also present at a younger age in Asians. And data from India is sort of limited to only 2 publications of about 400 patients or so. So we collected data from all our tertiary as well as our secondary center network over the last 30 plus years. And when we looked at the data of all pathology distribution in cornea, we found that ectasias formed about 7% of all our cornea patients that we tend to see in the hospital. Allergies was about 11% of distinct group. We also looked at the reasons for corneal blindness, or the reasons for corneal transplantation for patients who fall into the category of vision less than 20 by 200. And again, we found that about 7% of our patients were because of keratoconus or other ectasias, which are obviously much rarer. So over the last 30 years, we saw close to 21,000 patients, and we found that, again, as reported in literature, the male preponderance is maintained, with 2/3 of these patients being male and about 1/3 of these patients being female. Interestingly, when we looked at our data in buckets of 5 years, we found that the last 2 years, including the pandemic times of 20 by 20, was the time when we had the greatest number of keratoconus patients that we saw. And 69% or more, close to 70% of patients, of all the keratoconus patients that we've taken care of, are the ones that we've seen in the last 8 years. And this is actually leading credence to the hypothesis that keratoconus is probably being picked up more frequently or is more prevalent now in our populations. When we looked at the average age at which keratoconus was picked up from 1987, 1990 to the last 5-year bucket, we saw that there was a reduction in the age at which patients presented by almost 7 years. And this probably is also because of the fact that we are able to have more sensitive measures of keratoconus, and we are also more tuned to picking up at early. But it also is probably true that we are seeing patients who have keratoconus earlier than we were seeing them before. About interventions, again, where we looked at the kind of interventions that we do for these patients, and again, I'll look at this in more detail. We saw that of all the interventions, contact lenses are a very strong part of our management of keratoconus, and you'll see that the absolute numbers of contact lens patients still seem to be the highest in among those who have keratoconus. But also cross-linking is the one that actually is catching up from the point of view as a surgical intervention for these patients. When we looked at contact lenses, we found a steady increase in the percentage of patients who actually are prescribed contact lenses. And this probably also goes along with when we started our RGP practice in 1992, there was an upsurge. Then we introduced Rose-K, there was a further increase. And then there was a further increase when we introduced our scleral lens practice in keratoconus patients. There was a slight dip thereafter, but then again, we found a second surge, and this coincided with the introduction of hybrid lenses in our contact lens practice. Average age at contact lens fitting did not seem to be very different from when we started to what we have right now. When you look at surgical intervention, again, the most common procedure that we do right now is collagen cross-linking, followed by keratoplasty in these patients. Interestingly, we had a spike in the number of desmatopexies that we did for acute eye drops, and this corresponded with a publication in ophthalmology that we had about how desmatopexy actually helps these patients. But then later on, when we started to find that this causes significant number of anterior capsular cataracts, we've reduced the number of patients that we do desmatopexy for right now, and that shows you why there's a fall in these procedures. Average age is about 20 years again for desmatopexy for acute eye drops. Surgical interventions, again, you see that cross-linking is something we started in 2007, and that is a large majority of surgical procedures that we offer to our patients, reducing the number of cornea replacement procedures that we are doing. Interestingly, after introduction of collagen cross-linking, there was a slight increase, and then it's really taken off in the last 10 years or so, accounting for the largest number of interventions in patients who have keratoconus. And we're also seeing that there's a reduction in the average age at which we offer collagen cross-linking, and we're doing cross-linking earlier than we used to do when we started. About keratoplasties, again, we've seen a reduction in the trend of therapeutic keratoplasties and also a fall in our lamellar procedures in the last 12 years or so from our eye bank. And when we look at the distribution of corneal transplants, in the past, we saw that most of the transplants are penetrating. But from about 2000, we started adding lamellar procedures. And again, you'll see that the popularity of lamellar procedures has picked up and is more than 50% of the transplants we do for keratoconus right now. We still do about a 40% transplants as penetrating keratoplasty. And these are mainly in patients who have had hydrops in the past. Interestingly, the advent of collagen cross-linking also coincides with the time when we have a drop-off in the number of penetrating keratoplasties, as well as a flattening of the curve from the point of view of lamellar or DALC. And this, we believe, is something that is going to modify the number of patients who require these keratoplasties in the future as well. Average age at which we're doing keratoplasty is also lesser, and about 7 years lesser than when we really started doing this for keratoconus patients. This is also, again, shared in literature where in the Canadian experience also, they found that collagen cross-linking coincided with a drop in the number of penetrating transplants and DALC that they gave for keratoconus patients. So keratoconus accounts for about 7% of all corneal disorders and about 7% of all transplants is what we found. Incidence is rising and age at presentation is getting lower. Contact lenses and cross-linking seem to be reducing the need for corneal transplants in these patients. When we looked at age distribution, the most common age group was below 30 years, and this is something that we already know. And interestingly, geography, we found that most patients were from urban to semi-urban areas as compared to rural areas. And more patients were from the better socioeconomically affluent group than from the lower socioeconomic group. Most patients presented with a relatively good visual acuity, but there was a significant number who presented with vision of 220 by 200 or worse, which is a problem for us. Age at presentation, we also found that younger children presented with more severe disease compared to older individuals. And we also found that females tend to present with grade 4 keratoconus as compared to males. And also patients from semi-urban and rural areas presented with more severe disease than those from metropolitan cities. So what we concluded was 80% of keratoconus seems to occur between 10 and 30 years with a male skew, seems to be more common in upper socioeconomic strata, severe visual impairment in close to 15% of patients. Females and people from semi-urban and rural areas have more advanced disease at presentation. So the final conclusion is the fact that cross-linking and contact lenses are probably game changers to the way in which we will manage these patients. There should be increased suspicion in younger patients with refractive errors. You need to plan early cross-linking and monitoring will reduce the need for transplants. And we all should think about having screening programs to pick up keratoconus early and to actually have significant visual improvement over a significant period of their lifespans. Thank you very much.